This example of amplification of denial comes from a study that played a key role in promoting the notion that COVID is no worse than the flu. Early in the pandemic, we didn't have enough tests to diagnose everyone who might be infected with COVID. Epidemiologists understood that meant we were overestimating the case fatality rate, but we didn't have the data to say by how much. A group of Stanford professors very publicly speculated that we were wildly overestimating the severity of COVID in these opinion pieces. Within weeks, the authors were collecting data to prove their point, with funding from the founder of JetBlue. The authors recruited volunteers to drive to one of 3 locations in Santa Clara County to give a blood sample, which they then tested for antibodies. It is interesting to note that those authors included 2 economists and a hedge fund manager. The World Health Organization had estimated a case fatality rate of 1 death for every 27 cases of COVID. This study estimated 1 death for every 588 cases. And that conclusion played a major role in driving the false belief that COVID was no worse than the flu. In science, you are supposed to do the research and then talk about the results, not the other way around. That is especially true when you're funded by someone with a vested interest in the outcome. The accuracy of this type of study depends on 2 critical things: a truly random sample and an accurate test. The expert community immediately began to point out the flaws in the study. People willing to drive across Santa Clara County on a Friday to give a blood sample are not a random sample. Also, the test had not been well vetted. 2 Stanford faculty had told them not to use it and refused to be included as co-authors. But none of that really mattered. As soon as the paper came out, the hedge fund manager wrote about it in the Wall Street Journal. And it was all over conventional media. On top of that, it blew up on social media with over 20,000 ex-users posting about it. But was it correct? Epidemiologists knew our original risk estimates were probably wrong, but very few believed they were this far off. At the time the study was released, there had been almost 23,000 deaths from COVID in the United States. If 1 death meant 588 cases, then 23,000 deaths meant 13 million cases, and the CDC had missed 90% of them. The study was flawed, but there was no way to prove that the results were wrong. A year later, when the study was published, in a journal where one of the authors was an editor, it was already clear that the study was simply wrong. For them to be right, the 584,000 deaths that had occurred in the United States would have required 344 million cases. In a country of 330 million people, this seems unlikely. Their original risk estimates were based on an unvaccinated population, but most of the U.S. population has been vaccinated, and vaccines sharply reduce case fatality rates. Taking that into account, their estimate would require between 1,000 and 2,000 cases for every reported death. As of today, there have been over 1.17 million COVID deaths in the United States. So even if we ignore vaccination, their case fatality rate would require 690 million cases. If we account for vaccination, that rises to between 1.3 and 2.2 billion cases in a country of 330 million. Their risk estimate appears to be off by a factor of between 4 and 8. 4 years later, this study continues to have an impact. The preprint was never corrected. The paper was never retracted. They are both being heavily cited in the scientific literature and are still being cited on social media. This is a perfect example of amplification of denial. The research team pre-announced what they would find and had limited expertise in seroepidemiology. They were funded by someone with vested interests. Serious scientific criticisms were ignored. It was amplified by conventional media. It blew up on social media, and it was never corrected.